Good morning. I'm Deborah Spitalnik, Executive Director of the Boggs Center on Developmental Disabilities, and it's my pleasure to welcome you to the 291st session of the Developmental Disabilities Lecture Series. Today and all this spring, we've been glad that we can bring our community together even virtually, and we're glad that you're joining us today. The lecture series is a semi-annual continuing education activity of the Boggs Center, New Jersey's federally designated University Center for Excellence in Developmental Disabilities and Leadership Education in Neurodevelopmental Disabilities program. We gratefully acknowledge support for the series, which comes from the New Jersey Division of Developmental Disabilities and the Administration on Intellectual and Developmental Disabilities, Administration on Community Living, the U.S. Department of Health and Human Services. The Boggs Center is committed to supporting the developmental disabilities community in New Jersey as we face the coronavirus pandemic. We want to call your attention to COVID-19 resources that you'll be able to find on the Boggs Center website. These include general information, information accessible to people with developmental disabilities, information on mental health, self-care support, the use of masks. All the resources are in English and many are in Spanish. Before I introduce our presenter, Tamar Heller, I want to share a few details about the webinar format of today's session. On your screen, you'll see the slides during the webinar presentation. Handouts may also be downloaded. If you'd like to download slides and handouts, go to the Handouts section of the control panel, the gray box on the right side of your screen. The handouts will also be posted on the Boggs Center website next week with the webinar recording. We are planning to have a brief question and answer session at the end of the lecture. In order to ask a question, you have to type it into the questions section of the control panel. All attendees are muted for the entire program, and you will not be able to ask a question verbally. We encourage you to type in your questions during the lecture and not wait until the end question period. We will try to raise as many questions as possible after Dr. Heller's presentation concludes. We are pleased that we are able to offer continuing education credit for this webinar. To receive a certificate of attendance for continuing ed recognition, you must be logged into the webinar from start to finish and complete the evaluation at the end of the webinar. Certificates will be mailed to attendees who meet these requirements next week. As you complete the evaluation, you will note that there are opportunities for comment. Please let us know particularly about your experience of attending the DD lecture series virtually. Today's session will focus on identifying the challenges in serving adults aging with intellectual and developmental disabilities, and also to promoting opportunities for aging well. Adults with developmental disabilities are living longer than ever before. Families and service systems play a pivotal role in meeting the increased support needs of people with disabilities as they age. Many service systems are not yet prepared to provide appropriate care that promotes health and adequately addresses age and disability-related conditions. We also know that families themselves are aging and they may need additional support. All of these concerns are heightened by the COVID-19 pandemic. We are fortunate to have Dr. Tamar Heller with us today to share her expertise on innovative and promising practices to address these needs and support adults that are aging with developmental disabilities in obtaining fuller lives. Tamar Heller is a distinguished professor who heads the Department of Disability and Human Development at the University of Illinois at Chicago and its University Center for Excellence in Developmental Disabilities, a sister program of the Boggs Center. Tamar also directed the Rehabilitation Research and Training Center on Developmental Disabilities and the Health and Family Support Research and Training Center. Her research focuses on health and long-term services and supports for individuals with disabilities and families. She is Vice President of the Americas for the International Association for the Scientific Study of Intellectual and Developmental Disabilities, directs their publication committee, and serves on their executive council. Previously, Tamar was president of the Association of University Centers on Disability, a delegate to the 2005 White House Conference on Aging, and drawing on her lived experience, she was a co-founder of the National Sibling Leadership. She's been recognized for her research by IACID with the 2008 Lifetime Research Achievement Award. I want to say a heartfelt DD series virtual welcome and really welcome back to New Jersey to Tamar Heller, who will present to us today challenges and opportunities in serving adults aging with intellectual and developmental disabilities. Good morning and welcome back, Tamar Heller.
Hello, welcome everyone. Sorry that I can't see you in person. I was looking forward to having a reunion again at the Boggs Center, where I presented in 2006. I think, as Deborah noted, that right now, with the virus and what's happening and what is going on in the service system, there's even more and more attention needed to people aging with intellectual and developmental disabilities. I would like to give a historical perspective as we think about this. When I started working in this area and was asked to talk about aging and developmental disabilities, at that time, we talked about the specialized aging corner of segregated centers. So you might see, well, there's the senior part of the workshop. So that's the kind of programs. And what we did is we looked at the, whoa, what happened here? Jumped. Why is it jumping? Oh, here we go. That's weird. I didn't even touch it. Okay. We looked at these corners and we would look to the nursing homes for the kinds of programs they did. So, like, reality therapy or all the things that they used to do in nursing homes. Then we thought, you know what? Let's do what's age appropriate. And we talked about senior services that are age appropriate. Like, let's send people to nursing homes or to day programs for old people. So, because that's more age appropriate. And then, of course, as the field went, we go with the whole zeitgeist of the field. We moved into person-centered planning for later life and looking at being more individual of what people need and want. And so some people might want to go to a senior center. Other people may want to continue working. So much more person-centered. And we moved on to really being part of the community, not just being in the community, but really included in the community. And more recently, the human rights approach, which really looks at people with disabilities as citizens. And so you can see how the way we think about aging and DD very much is similar to how we think in general in the field and where this field is going. Now, that doesn't mean that the older approaches aren't still here. And we know that those older approaches are mixed in with the newer approaches. And, you know, that's the way that it works. So if we talk about what is successful aging, it's really interesting because aging without a disability is considered one successful aging. So we call that ableism. It's interesting, we had a well-known person in the field speak at our center, and the title was Preventing Disability. And our students were very upset with that. You know, we have a program in disability studies, and they started putting X's all over the posters about it. And I told the person, please don't talk about preventing disability. Can you change the words? And he wouldn't change it. So he said, well, we're trying to prevent further disability. But I think it's the words that are used. The other part is the emphasis to staying useful. So we call that ageism. And the whole aging network is very much focused now on looking at more positive ways of thinking about aging and the way it's framed. And I think we've been doing that with the DD field for a while, thinking about that. And the aging world is a little later with some of this. On the other hand, there's this concept of compulsory usefulness. This was coined by one of my PhD students, Haley Gibbons, which I thought was really brilliant. And it's looking at the fact that we have this notion that somehow if you get sick when you're older, that maybe you did something wrong. You didn't have good health behaviors. You're kind of like a failure. And so, and if you, and we see this with Hollywood, et cetera, if you have wrinkles, et cetera, you haven't taken care of your face, or you haven't, you know, done plastic surgery, whatever. What it does not account for is that many of the reasons why people have end up with chronic health conditions, some of it has to do with access to health, with poverty, with all these social determinants of health that we talk about now. And often there's kind of a blaming of people. So I think that's an interesting concept, and thinking about what is the state's responsibility versus personal responsibility. So how do we address some of these issues in a way that is really respectful of people and people who already have a disability? So first of all, we want to see how people with intellectual disability view aging. And we want to adopt empowered frameworks so that we understand what their disability identity and how they feel about their disability. And the notion that there's nothing wrong with dependence and interdependence. None of us are totally independent. We spend so much time talking about, oh, we want to be independent. And so many of our earlier goals used to be for independence, productivity, and community integration. But interdependence is part of life. And we need to take into account the role of minority status, poverty, culture, and taking a life course approach. And we're seeing the importance of looking at what people do earlier in life and how that affects later life. In fact, now there's research that even what happens when women are pregnant, that can affect aging of their child. So what do we mean by aging well? First of all, I like to think of living on your own terms. We say as you get older, you get more and more like yourself and more different from others. And so we need to respect how people are. And I see this with the virus now. I can see that, for example, I have one daughter that likes to be sort of at home and working that way, and you know, and for her this is okay. There's other people who are so social and it becomes so hard, this virus of shelter in. They want to add value to society, family, or friends, and then of course maintaining health and function. We all know about the extended life expectancy, And I didn't send a bunch of statistics to you about that. And we do know that people with IDD, if they have severe levels of cognitive impairment, Down syndrome, cerebral palsy, multiple disabilities, they do have a shorter life expectancy. But this is rapidly improving quite a bit. So how do we find out what people feel about growing older? Well, certainly doing interviews. Here's an example of some interviews that we did with older people. It means that you are settled and know what you are doing. I am more kinder. I get along a lot better. I have friends I am happy with and that I do things with. For the future, I wish that I keep going happy and that I don't feel old and that I'm not in a wheelchair. This gentleman was interviewed. I feel people 50 years and older have the same chances as younger people have, and more, especially people with disabilities. Finally, I feel older people with disabilities shouldn't let their age or disability stop them from getting the job of their dreams or having fun. So we look at the interaction of aging and IDD and life transitions. These are some of the issues: the development of chronic health conditions, changes in family caregiving and supports, retiring from employment, and receiving end-of-life care. Those are some major transitions that happen. And we all know that transitions are often very difficult at all ages. I'm going to talk some about the health of people with IDD, not in great detail, but I want to give some context to some of the issues that come up. We know that people with IDD have poorer health and earlier age-related conditions. One of the areas is dementia that this is more prevalent at an earlier age in people with Down syndrome, who often get the dementia 15 to 20 years earlier than other people. Osteoporosis is a big issue, and that's often tied to the medications, for example, for epilepsy or people that are using wheelchairs. Oral health is a very big issue. In fact, one of the problems, for example, in Illinois, is that there was something called the SMART Act, which I would call the Stupid Act, which actually prevented people on Medicaid that had disabilities from getting preventive dental care. And of course, we've done research at our center that shows the relationship between oral health and cardiovascular problems if you don't have good oral health. Diabetes tends to be a little higher also with people with IDD. Secondly, there's higher rates of falls, and especially people who are on medications. It seems to have some relation with that. A big issue is the obesity. We have that issue in the general population, but it's even higher, and the gap continues for people with IDD. And part of the reason is sedentary behavior. Well, even before that, some of that has to do with genetics. So we know, for example, Prader-Willi, people on Prader-Willi have a compulsive eating. Some of it, people with Down syndrome have shorter muscles. So some of that, certainly it interacts with health behaviors. They have more sedentary behavior, a lot of TV watching, maybe now computers, but I see when I go into group homes more TV watching. Unhealthy diets, and people who live in poverty often don't have as much access to good fruits and vegetables. And certainly all this is related to the health-related quality of life. There are many issues with access to healthcare, and one of the aspects is that there's a diagnosis of cancer at a later stage. And I think that means that when they do get the cancer, they are more likely to die of it. Polypharmacy is very prevalent, and polypharmacy is, in general, for older people, is a really big issue. because it's not that uncommon for some to have more than 10 different medications. One of a recent study found that there's deaths that are amenable to healthcare intervention, and that we see more of that in people with IDD. The lack of testing and treatment for COVID-19 is a really big issue. And I know in Illinois, I can tell you that it's been a really big issue here of so many people having that and not necessarily getting tested. They had to bring the National Guard out to one of the centers in Illinois to do testing. But in general, part of the problem is they may have difficulty communicating their symptoms or understanding the prevention instructions. There's that whole issue of rationing, and it's really not allowed, but there was a real issue, especially at the height in, for example, what was happening in New York and some places where hospitals just didn't have enough ventilators. There's the prevention of allowing support persons to come to the hospitals, and several hospitals have instituted where they will allow a support person to come, and it's also some of the CMS guidelines are saying that you really need to allow that. And we need to know the rights to equal access and support. So it's especially important that we know about these rights and that we advocate for people, especially people who are aging with IDD. You're going to see more of these, and they're going to be more vulnerable. You're going to have worse outcomes with age over 65. So we know that as a fact. Worse outcomes for those with chronic conditions such as heart, lung, diabetes, obesity, which you can see again ties in with what some of the conditions that we just talked about for people who are aging with IDD. And we know there's more cases in long-term care settings. And I know that both in New Jersey and in Illinois, we've had a high number in our developmental centers. And I think in group homes, we don't even know how many are there. So what about strategies to reduce disparities? So these are some of the things that I'll be talking about. Greater knowledge about impairments and treatments is really important. And there's all kinds of initiatives around education. Reduction in poverty and unhealthy environments. That's a tougher one to tackle, obviously. Improved health behaviors through health literacy and health promotion. Improved access, accessibility, equity, and effectiveness of healthcare, and better health and fitness in later life, hopefully, is the result of that. So these are some examples. For example, the Health Matters curriculum, and I know that you had some training in the Health Matters, not that, I don't know, was it in the last few years? That's an exercise, nutrition, and health education curriculum for people with DD. And I'll tell you more about that since that came out of our center. Living Well with a Disability comes out of the University of Montana and is also these are both evidence-based curriculum. The Living Well with a Disability is more general, not specific to IDD, but has been used also with that group. And We Walk is a new one that Kelly Hachey has developed from our center around a walking program. Health Matters has quite a few different kinds of training. They have a peer training, which I'll tell you about. They have something called Getting the Memo, Creating a Culture of Health Promotion, kind of how to, and also signs and symptoms, how to observe changes in health conditions. It's very much focused on, all these programs are very focused on getting community-based organizations to develop health promotion programs. So they deal with different aspects of that. This slide basically just shows you how you develop to have massive dissemination. We went from a clinical, very research-based program at our center, the university-based clinical trial, very much, National Institutes of Health kind of research in a kind of a standard kind of way. And then we moved to taking it to the community, because what we found is when we did the training and we brought people to our center and we did all the things you need to do, that then when we tried to use the same program outside at the community-based organizations, we really had to make some changes. And the other thing we found is that if you don't go to the agencies, then many of the good things that happen don't get continued afterwards. They don't get sustained. We have since developed partnerships with statewide organizations and have done major scale-ups. And so this is what it shows. So 10,000 individuals with IDD have been served. We have 2,600 certified instructors, 210 organizations in 35 states. And I'll just tell you a little bit about that. Beth Marks and Yasmina Cicerak are the primary people running this at this point. Here you can see we have the curriculum, but we also have a book that's about the train the trainer of how to create a sustainable health promotion program. So that's the really important part, is to keep things going. This is kind of an original picture that we had when we developed it. It was based on stages of behavior change theory. And I just sort of love these pictures of how you think about it. And this is for any behavior change, really, but we tried to make it very simple. The reason you see so many people with Down syndrome is because our first study was included only Down syndrome in the very first study that we did. So here you have, I'm thinking about it, contemplation. I'm making plans, preparation. I'm doing it, action. I'm still doing it, maintenance. I skipped, I'm not interested, pre-contemplation. And then it can be, I'm stopping, and then relapse. So we know that this is how it often happens, and our chapters in the book are based on this thinking. Here's just an example of how we modified our fitness classes. When we first developed this, I got to work with Jim Rimmer, who's an exercise physiologist and a major researcher in this area. We had a team of nurses and nutritionists and physicians and exercise physiologists, and I myself am a psychologist. It's a 1 hour of health education class 3 times a week, 36 interactive classes, personal notebook. You can see some of this on a YouTube video that you see that I have here. The main thing is it really grew out of our person-centered planning for later life, with very much of a focus on self-determination. So it was about understanding their attitudes towards health, exercise, and food, finding the exercise they like, and setting goals so they could gain knowledge about exercise and eating well. They could support each other during the course of the class and identify places in their community to exercise. So this was part of the plan. And the self-determination choice became a very big part of it. And, they loved there were certain tapes that they just loved. Simmons was their favorite. The idea of self-responsibility and involvement in planning and goals. The changes in their health behaviors and getting support from caregivers. That became a big thing, because what happened is I had this idea that we would have one group that we would work with their direct care workers that would support professionals that would come in with them. And then we would go back, we went back 6 months later to see how people were doing. And it turned out that the people we had trained, the direct support professionals, were no longer working there anymore. So we saw that that wasn't a good model of just bringing in a couple people like that. Here's just an example of good pain, bad pain, just trying to show with the pictures. So what did we find out? So the immediate in our original research study was that knowledge about exercise went up, confidence in their ability to exercise life satisfaction, lots of these fitness measures improved, caregiving perception of exercise benefits improved, and access barriers were decreased. So this was our kind of original studies that we did. So we then went to more of a train the trainer curriculum. And part of the impetus for this was not only that when we went back to the agencies and saw the direct support professionals, many, because of staff turnover, were no longer there. We were also asked by Special Olympics to work with, they were giving, I think, $10,000 to $15,000 to different Special Olympic chapters to do health promotion. And they wanted us to do the evaluation, and they were suggesting that some of the places used our curriculum. Well, then we said, we really had to figure out how to do the train the trainer. So that's what got developed. And it was basically to provide staff with the skills, knowledge, and abilities to implement, teach, and support the development of this. So some of the interesting findings in terms of training of staff is that when the staff were trained, they had improved energy and less pain. They also, many of them had very poor health behaviors. They had improved psychological well-being. They had positive exercise and nutrition expectations. They developed more environmental supports for nutrition. Their knowledge of fruit and vegetable intake recommendations increased, and the organizational policies that support health promotion for direct care workers improved. So it was kind of interesting to look at the impact of training on the staff themselves. Really, so much of the success of these programs has to do with enthusiasm of staff. And it also had, of course, impact on adults with IDD. And compared to the controls, they had less pain, increased self-efficacy, that self-efficacy to around exercise and nutrition, and increased social environmental support for exercise and better nutrition. I just want to say a little bit about the exercise classes. They were 1 hour physical activity 3 days a week, and the emphasis is on flexibility, cardiovascular endurance, muscle strength, and balance. So a good exercise program has all that. And there are different guidelines for the frequency, the intensity. So, how often you should do it. Intensity usually needs to increase over time. Stretching is very important. And using the equipment and exercise safely. The first day when we started the program at our institute, a gentleman got on the treadmill and fell on top of one of our researchers. And then we had to go to the IRB, the Institutional Review Board, and we had to do, it's so important, the equipment and exercise safety aspects. Some tips for starting a program. First of all, getting an okay from a healthcare provider, because some people do have limitations. The importance of incorporating physical activity throughout the day. I know that all of us know that now that we're kind of stuck in the shelter in place, I have 8 stories in my house. I've been walking up and down the steps a little and trying to get outside, but thinking of how to incorporate physical activity when you can't go to a health club, or we're so limited in what we can do. It needs to be tailor-made for the person, of what a person likes to do. Certainly, you've probably seen that exercise a minimum of 3 days per week, 30 minutes. Moderate intensity, of course, the more intensity is better. And it should be progressive. Most importantly, it should be fun and rewarding. And you need to foster fitness. So it's a culture of how we think about that. This is a program plan inventory that was developed, and I'm not going to go through this whole list, but it has all the different aspects that you should think of as you're planning in terms of developing a program. Well, you don't have to have fancy equipment. Here's an example of sample circuit training, where you can just do sort of a small amount of each thing, and you just do a bunch of different things, which I like this one. It's kind of a fun one with bicep curls, jumping jacks, wall sits, all kinds of things. So it's kind of a fun thing that you can do easily. Very important to have caregiver support for exercise, giving encouragement, offering to do it together, planning for exercises on recreational outings, discussing ways to get more exercise, ensuring transportation, identifying ways of paying for it, and showing how to exercise. One of the things that we found early on is that, and this was even in the early later life planning, planning for later life, the person-centered planning for later life that we did, that often with people with DD, if you want something to happen, some changes, you really have to give that support, and you really have to be there to help, and to, whether it's transportation or whatever it is, definitely without the support, a lot of changes don't happen. And the same thing with nutrition. We really need to encourage healthy food choices. You know, I have to say that, you know, I tell a story sometimes about, you know, I have a sister with developmental disabilities, and she became extremely obese, and, you know, to the point where it was jeopardizing her life. And she actually almost died, and was very, very difficult situation. And eventually she got into a group home, a pretty good one, and she got motivated and ended up losing, first of all, she had very severe diabetes too. But sometimes she was over 300, her sugar. And what happened is somehow one of the staff somehow took an interest and somehow got inspired, and she ended up losing weight. She lost 150 pounds and did not have the diabetes, or at least it was very controlled. And it's very interesting that just very recently, since this virus thing happened, she's gained 30 pounds. And, you know, you can really see the difference, because mostly it's not self-control from what I've seen. It's done with her with self-determination and choice, but she still needs help in order to be able to do that. And one of the ways, for example, with Prader-Willi, she doesn't have that, but with Prader-Willi, that you can honor self-determination at the same time is sometimes there'll be like a contract that, please, you know, I need to lose weight. Can you control and lock the refrigerator? It's kind of a contract that people make, and that they acknowledge that they want to lose weight. They just can't self-control. So you want to encourage healthy food choices, assist in developing plans and goals for changing eating habits, reminding people to avoid the high-fat, salty foods and to eat more fruits and vegetables, and to compliment people on changing eating habits and offer fruit and vegetables as a snack. One of the changes with the virus that happened, for example, in my sister's home, is that in all the group homes of this agency, they now have live-in staff instead of rotating staff. So they've had the same 2 people this whole 6 weeks. And since people are living there, then the kind of food they're getting is probably the food that the staff likes too. So kind of interesting. I don't know if that's part of some of the changes that happened with her. So how do you have sustainable health promotion programs? You need supportive environment and the attitudes within your organization, and the policies that will support the health and safety, and the supportive attitudes among staff and management for healthy lifestyles. So one of the projects that Beth Marks and Yasmina Sisarak have been working on is on spreading the word. So how do you do that? So you have a curriculum. So many curriculums are developed and they just sit there on the shelf, or some people do it and it's kind of limited. So they work with a local state entity, and then they conduct requests for proposals, conduct webinar trainings with certified instructors, develop wellness committees at each of these community-based organizations that get picked. So I know, for example, that's what they did in Kentucky, which I'll show you. They conduct Health Matters assessments and evaluation, which is basically those questions about, what is the current climate and what do they need to do? They implement the program and develop sustainability plans. So just an example, Kentucky was one of the very successful ones where they did the Health Matters assessments. They did webinars to get people certified. They had the community-based organizations complete letters of commitment, and that way they embedded it within the organizations. A second program is called Peer-to-Peer Health Messages. This grew out originally from Special Olympics, asked us to help out with their peer training of their athletes. And then it developed into this peer-to-peer health messages program. And it was a train-the-trainer program to teach adults with IDD to become coaches along with staff mentors, and focused on teaching participants to increase their weekly physical activity and drink more water. It's pretty simple. It has those two big messages with a 75-minute webinar toolkit and paired with a mentor in learning content and developing leadership skills. So that's been a very popular kind of program. It's 12 sessions with about 10 people. That's what the peer-to-peer. And there's booklets and these fun wristbands, and each of these wristbands have the message of the week for the 12 sessions. So one of them might say drink water. So that's something that's been very popular. So why would you have peer coaches? Well, one, they can share the health messages. Their people are about the same age, they have common interests, and it benefits the coaches themselves as well. So it's kind of a neat concept. So there was research on this peer-to-peer using randomized intervention, and the coaches increased their own physical activity and hydration knowledge, and the mentors increased confidence to teach the program. The program participants themselves increased their physical activity and hydration knowledge, increased their social support for engaging in physical activity, and they improved their own physical activity and hydration. So this really shows that the need to include health promotion in community-based organizations with their mission, vision, and job descriptions. Another program that is in an earlier phase, it's called the We Walk program. I was giving a talk once and I was talking about our the original exercise and the curriculum that we had developed, and I was showing all the fitness equipment, and someone said, well, why can't you just do anything like a walk program? And we said, well, yeah, that does make a lot of sense because not everybody has a whole gym to use. And this We Walk program is an idea of actually using technology interventions to improve the physical activity of adults with ID and their family caregivers, where they would walk together. A little harder with those of us in New Jersey and Illinois where it gets cold in the winter, but of course there's also mall walking that used to be popular. Right now could be a little difficult. But also the use of technology actually is quite useful now, where people are starting to get more and more used to technology. And as we think about that, and so this one had a single group pre-post design, and driven by the same kind of theories that we used in the Health Matters of the social, cognitive, and self-efficacy theories of Bandura, which is basically so that people develop confidence in what they're doing and get the support for it. It's a 12-week walking program, and it's wearable physical activity trackers like Fitbits and texting messages, and these go to the caregivers as well. And what we found was an increase in moderate and vigorous physical activity. Here's just a picture to show you how we did the training. We did baseline assessment. through the Fitbit data, 12-week intervention with texting messages. And these messages were also very much individualized to the person. So what are some key issues in healthcare? And this becomes really important now as we think about what happens with the COVID and the fear about rationing, and especially for older and disabled people. And this has shown up, for example, with the issue of organ transplants or dialysis. So think about the key criteria. So we have key criteria of years of life expectancy. All right, well, think about people with Down syndrome who have 15 to 20 years less in terms of life expectancy. So if you have a rule that people 65 and older can't get a transplant, it's very hard to get one, actually. For example, kidney transplant. What about someone who's 50 years old with Down syndrome? The ability to keep a regimen. Again, that could be an issue for people. And how much support is available? And the big question, I don't have an answer to this, is will these interventions improve quality of life balance with burden for persons and carers? So these are some issues that are really generally for older people and people with disabilities. Ezekiel Emanuel wrote a paper, maybe it was like 10 years ago, maybe less. And in this article, he was talking about how people 75 years and older, we should not be doing extraordinary health interventions with them. And I was staying at someone's house who's a physician. And I went downstairs and I said, look at this disgusting article. Because I was really appalled the idea that you're 75 or over, you shouldn't get extra treatments, etc. And my friend, who's a physician, a very good one, actually agreed with the article, because she said that, yeah, we do all these extraordinary things that we shouldn't be doing. So anyway, it's just an interesting, it comes up now with the issue around ventilators. The other issue is health checks and preventive screening, looking at risk versus benefits. We see this coming up around mammography right now, and when we should do it, or prostate, when we should do the screening. But we need to make sure there's equality of access. And then patient-centered care and health literacy. There's a need for health literacy education. That's really, and this is coming up now also with the COVID, and trying to explain to people. And I see that the Bog Center has done some really nice things. I see that my page got changed. That's okay. So what is good healthcare? So we did a study where we interviewed people about what they saw as good healthcare. So these are some of the things people said to us, people with IDD. Getting their needs met through access to quality services. I was able to receive a good psychiatrist, one that has been really helpful to me, and I was able to get my glasses. And humanizing treatment by healthcare professionals. The doctors have been listening, and they find the better solution. And skilled, knowledgeable, and experienced providers. My doctor tells me to take my pills every day and sees how I am doing. My doctors take care of me good. I understand when they talk to me. And then we know the barriers. And this was the biggest thing that we heard from quite a few people who said doctors who did not demonstrate respect for them. I am unhappy with my doctor. If he's the only one there, I won't go. I know that's bad for my health, but he is very rude. It makes me feel stupid. I know my body, and I know if something is wrong with me. He thinks he's better and smarter than I am, and we bump heads. And delays in getting services. I needed a personal assistant, and it took a long time. Had to have family members help, and they didn't always know what to do. So I'm going to go back here. So we did a conference with Rush Hospital. It was actually led by Rush Hospital in Chicago, looking at healthcare. And I had my sister speak about her good experiences and her bad experiences in healthcare. It was kind of exciting for me because we had the executive director, the presidents or the chief operating, the directors of the two hospitals, University of Illinois and also Rush Hospital speaking. We had a professor from Harvard and then my sister who had never really spoken before. And she talked on this video, which is actually on YouTube, of her best experiences and her worst experiences. And one of the experiences that I want to tell you about that was her worst experience is she was in a bad accident and had on her behind, had an ulcer on her behind. And she called me at, was 9 o'clock in the morning and told me that very upset that the nurse hadn't come to clean her from a bowel movement. And 3 hours later, she called me and said the nurse still hadn't come. And when the nurse finally, finally I called and I called the nurse administrator, and the nurse administrator said to me, those people have no concept of time. And I said, do you need a PhD? She called me at 9 and now it's 12. So, you know, there are issues like that. But then she tells her great experiences and how she had this most wonderful doctor at Rush Hospital that saved her life. And he really saw her humanity. And he was just wonderful. He would, I would call him and he would talk to me immediately. He thought that she had a great sense of humor and just was amazing to me because he was like this amazing surgeon that saved her life. So you have all kinds. We don't just complain about healthcare. We did, oops, let me go back. Oh, sometimes it goes, it's going the wrong way. Why can't I get it back? I can't seem to get it back. Can we get this back? I'm hitting the arrow back and it's not going back. Okay. We'll go to here. So there's different materials that have been developed. This is a nice one called My Health Passport, which was developed in Florida at the UCED in Northern Florida. And it's just a very simple My Health Passport that has, you know, just important information about the person. I think during the pandemic, this is especially important. And there's different versions of this kind of a thing. So you can get that on the website. There was a documentary made by Rush in collaboration with Georgetown University called None of Us Want to Stand Still. And it's about healthcare and IDD. Actually, my sister has a minute in there. It gives voice to advocates to share their stories and examples of how changes can be made on all levels of a healthcare organization to better treat these patients. These two hospitals have really been in the forefront of really thinking about how to address issues. And in fact, when our hospital was not allowing personal assistants to come with people with IDD, you know, because of the new policies around the COVID, I took the Rush policies and sent it to our hospital to get them to change the policies, and they did change the policies around that. I'm going to switch so that I am finished with the section on healthcare, and I'm going to switch to other issues. And now I'm going to switch to issues of families and long-term services and supports. So we know that people are more likely to live with parents and that families and persons with disabilities need to engage in future planning. So that's a very big area that's that's important. And these are just some numbers that maybe many of you have seen about how most people with IDD live with family. And again, 71%, and maybe slightly different in each state, but this is basically from national data. And not, you may think that so many are in residential settings, but there aren't so many, only 13%. This is from FY 2015 in terms of from the Braddock et al. Studies around the state of the states in developmental disabilities. And we also know that very many are with aging caregivers, which we say 60 and over, it's 24%. And then there's that next group, about 35%, age 41 to 59. And you may have seen this quite a bit in terms of, and it varies just slightly in different states in terms of that. And these are estimated numbers. What is interesting is how few families are actually supported by the state IDD agencies. And this is the national data, and you see about only 15%. So we know that a lot of people do not get the support, and many families are caring for people at home and not getting the supports. So what is the lifelong impact? What we've seen from the research is fewer opportunities for employment, and that's for the mother. Restricted social network is another one for this is for the families, mostly the mother. It has the impact on physical and mental health and stress for some groups more than others. With autism, we see more stress. We see more stress around minorities and more health effects. And certainly greater difficulties as parents and persons with IDD age, as Deborah mentioned in the introduction. But caring also has its positive aspects. I can tell you that more than 90% of families in surveys I've done have said that having their son or daughter with disabilities brings meaning to their life. And we also see, which, let me see if I have that. We also see that, I'm going to go back to this, that in many cases, the person with developmental disabilities is caring for their parents. Sometimes that's underreported by parents, but it's really interesting to see that and that gives a lot of families satisfaction. On our advisory board for when we had the Research and Training Center on Aging and Developmental Disabilities, we had a lady with Down syndrome. She was about 50 years old, and her father was a very famous pediatrician in the state of Ohio, and he developed Alzheimer's, and she cared for him until his death, and she wrote a little book about it that we had. Well, here's two negative stories. Worry about future care is huge. And I have this quote, "I wish my child dies 4 minutes before I do." That sounds horrible. And when I was doing focus groups around this issue, I heard this in a suburb in Chicago. And many years ago, I did not hear it when I did focus groups in the rural area. I did not hear it in the inner city. But I heard it in the suburbs. And I heard it from my own father when my sister was in dire straits. And I remember when my daughter says, "Why does he hate, my sister?" And I said, "No, it's because he loves her and he worries about the future." Well, what happened is that there was actually have been stories where parents actually murder their son or daughter with disabilities. So why would an 82-year-old man kill his son, his daughters, his wife, and himself? So this was really desperate. And the odd thing is it was exactly in that suburb where I did that study. And here's another issue, another case, again in the Chicago area. And there was a woman who had adopted a child with cerebral palsy, cared and loved this daughter all her life. This mother became ill herself and was very worried about the prospects for her daughter, and she actually killed her daughter. And she pleaded guilty to involuntary manslaughter in the death of her daughter. So the outcry was they weren't going to sentence her. There was this feeling that somehow that killing someone with severe disabilities somehow wasn't the same as killing someone else. And there was a big outcry after that. And so then eventually she did go to jail. And then she ended up dying in jail. So anyway, those are the bad stories when people. So I never used to tell these stories. But then I heard about stories like this around the world. I heard in Belgium, I heard in Israel, I heard in France, these kinds of stories. And it's only because of desperation that you hear stories like that. That's why it's so important to do future planning. One aspect is, in terms of future planning, is the siblings who play a role in thinking about the future, because they're the ones who are going to end up taking over. Here's a picture of the club sandwich generation. And I know that you also had Katie Carling Arnold, who's actually from New Jersey, come and speak about siblings. She's the executive director of our Sibling Leadership Network. And we also talked, it's not just a club sandwich, but siblings may be taking care of grandparents, their kids, their brothers or sisters, so at many levels, intergenerational. This is a picture of my mother and my sister, and this was at my father's 90th birthday party. And my whole family came to Chicago because because my sister couldn't travel, and so they all wanted to be here, and that she would be included. So the Sibling Leadership Network right now has over 5,500 siblings and supporters, and this was started in 2007 by a couple of us who really thought that we needed a national network. There's now 27 state chapters, and it focuses on resources, research, advocacy, and it's really about advocacy with and for brothers and sisters with disabilities. Another family support resource is the National Community of Practice for supporting families, charting the life course. I don't know if New Jersey is one of those states that's using this program. It's developed out of University of Missouri, and the visual, they have really nice visuals, but really thinking about family support throughout the life course on many different domains of life, thinking about each of these aspects. And they have a wonderful website to look at. And one of their emphases is that many people are not getting public supports, like I said, and that we need to think also about how to provide family support to those families. We've been directing the Family Support Research and Training Center, and there's some promising practices that I'd like to tell you about. And we're in the last year. We kind of got a 1-year extension on this center. One is Caring for the Caregiver, that was developed by Sandy Magagne, who's now at University of Texas in Austin. And it's really a whole training program primarily for the mothers. And it's focusing on Latino mothers, and working because so many of them had health problems. that were doing caregiving, they were neglecting their own health. The second one is Future is Now that we developed, and I'll tell you a little bit about that. There's also, and actually the Future is Now was partly inspired by something called Plan that came out of Canada in terms of thinking about issues around planning for the future. Indiana had a social media to support families project. And certainly the ARC Center on Future Planning now has a big center on future planning. And I've got the link there. They've got lots of online materials that you can look at. A little bit about the Future is Now that I'll tell you about. And this was something that is evidence-based and was researched. And it showed that we did research before that showed a need and for this kind of thing. And you know that we know that most families don't do the planning, and even we did research a long time ago, and new research is showing the exact same findings, the same barriers, the same findings, the same that at least 50% don't do the future planning. And I know that the reasons for that so many, it's very anxious to think about the future. But, you know, certainly we saw there was a big need. We tried to experience all different kinds of interventions. Some worked, some didn't work. We found it was really hard to actually get families to sit down and make these plans because a couple of reasons. Not only was it anxiety provoking to think about, it was also sometimes the options are so bad that are out there. Again, we're hearing now about the importance of planning being even more important now with the COVID virus and you know with uncertainty about health issues. The purpose of the Future is Now is to develop future planning goals and developing a letter of intent, which is like a roadmap, and it's not the will itself. Increase the advocacy for supports and thinking about what could be. And what we found in the research was that the caregivers experienced less burden, including less worry about the future. And this was you know, with control groups and 1-year follow-ups. And the persons with IDD had greater voice in decisions about later life. We have since redone the curriculum, and this is a newer version that's on this slide that we've been doing. There's the different sections of the curriculum. Is the first step is identifying the dreams and nightmares, and and there's lots of different tools for doing that now, and thinking about that are out there. There's also a lot of different curriculums that actually look at future planning. What might be more unique about this one is the fact that we work very closely with people with disabilities, with peer trainers, which I'll tell you a little more about that. So identifying the dreams and nightmares is an important one. Looking at the relationships and the support networks, the desired living arrangements. That's probably the biggest issue for people, is where someone's going to live. The post-secondary education, work, and retirement. Many people with that are older with IDD want to continue working because or go to, if there's a day program, they want to be still involved. And identifying the key succession person, that's a real key issue. Who will take over? So we know that learning takes place over time and things change continually. And families learn from each other and support each other to take risks. So we've been trying to develop sort of an online version of this. And I think that's a real challenge, because there is still something about when people get together and talk, and we see how much people really benefit from being together. We sent homework assignments. We tried to break the process into manageable steps. We do a pre-session on legal financial planning. That's one area that's really important for people to do. And now with the supported decision making, you have many more options of what can be done. There's a facilitator's guide for families, a workbook for families, a facilitator's guide for people with disabilities, and a workbook for people with disabilities. So what is unique is the integration of person-centered and family-centered philosophies. And what I'm saying about this is that sometimes they clash, because we found situations where, for example, we had, in one of the trainings we did, we had 3 siblings, and the sibling with Down syndrome wanted to live with the sister, but the sister didn't want him to live with her. But the other brother thought that he should live with the sister. So there's a lot of family dynamics that need to be worked out. That's not so simple. There's peer support. So we have people with disabilities, and we have families that support each other. And they're actually in different rooms working on the issues, and then they come together to work together. So it's very much problem solving together. We've been challenged to think of how to do this online, which, you know, there's so many of these future planning type curriculums are really done, even though they say that, you know, involves the person with disabilities, etc. They still primarily where the families basically just fill out a life plan of some sort. So problem solving around family dynamics is a really big issue, and it brings into all kinds of issues of thinking about one's own family and one's values. It's a very emotional process. And I found that sometimes we ask families kind of what's their mantra or kind of the values of the family. And in one family that we had, there was a mother, a sibling, and a person with autism, who actually, we had a person with autism, we had a person with Down syndrome. The guy with autism had an MBA. I was talking about financial planning. So it was kind of interesting. But without seeing each other's and what they wrote, all 3 of them wrote compassion is their value in their family. So it was kind of interesting to see what it is in each family that is important. The letter intent is important and includes essential information about the individual with a disability. And actually, the Center for Future Planning on the ARC has also a very nice letter of intent that can be done online. You know, we had one that we developed. You know, theirs is really nice to work on. Well, one of the things that we've been trying to do is using train the trainer approaches, because, you know, you can't go out and do a bunch of training, but if you really want to have an impact, you need to figure out a way to get something out there. And I noticed, for example, the ARC is now doing these trainings online. We did train the trainers online. We did basically a request for proposals through the Family Support Research and Training Center. We also worked with the ARC Center on Future Planning on theirs and getting that out. So we piloted 2 types of future planning interventions for professionals working with adults with IDD. And we evaluated the outcomes. So what happened there? Okay. And what happened, I guess I'm missing a slide here. Am I missing a slide? What we found is that this was we were able to do this online, and turned out to be very effective in getting people to actually implement various train the trainers. So in the first group that we did with our own curriculum, we had 25 different agencies apply around the country. And we picked 3 where we actually gave them some funds to actually go and to implement the train the trainers. So that was one way of being able to do that. In terms of end of life issues. We know that there's an under recognition of the health issues for people with disabilities, and there's a need for palliative care training. But there's greater barriers to hospice care. And there's that whole issue of understanding of death and losses. We call it disenfranchised grief because it's not always recognized that they have the grief issues. And we know there's training needs of staff. And actually, the Boggs Center has been a leader in some of these issues. I know through the work of Bill Gaventa before. We had developed a curriculum on death and dying, and its emphasis was on teaching concepts of death to people with IDD. And it's interesting that when we first did the curriculum, I have to say, we had a person working on it who was came from the education field and was kind of anti-religious, and had a section in there that says they wanted to teach the fact that when you die, you die, you're not coming back, and you can't return to life. And they said, when you're dead kaput. And we had then someone working for us who was very spiritual and believed in an afterlife. And she said, you can't put that in the curriculum. People have different kinds of beliefs. So we really changed it to be much more accepting of all different ways of thinking about death. But still wanted to be clear that you're not going to physically see the person again. And the notion of understanding grief and the emotional responses and the behaviors that people have. And then different kinds of ceremonies around mourning and rituals, and the fact that it's okay to feel pain. So, and then also, what are some of these rituals around funerals? And, we have also the issue around assisted suicide and disability. It's allowed in 5 US states, 51% in the US, and some surveys found that they were pro for assisted suicide. However, this is really controversial with people with disabilities. And even among our faculty in disability studies, we have one that believes that it's okay, and most of them who think it's a really bad thing. The one who thinks it's okay is because he's basically pro-choice, and this is part of pro-choice. On the other hand, most of the disability advocates are very concerned about assisted suicide because they think equating disability with a poor quality of life is the problem. And also that people are concerned about the burden on the family, and that if a person feels they're a burden on their family because the family's not getting support they should be getting, or maybe if they're not getting proper palliative care, etc., then they may want assisted suicide. Those are some of the concerns. Some of you may remember the Terri Schiavo case, where she was not terminal, and so there was an issue of whether to withdraw food or not. So here's an example with eventually they did take away the feeding tube. So I've been talking about different issues specific to aging and IDD. We know there's a need to bridge aging and disability, because aging as a field has a lot to contribute to the disability and vice versa. There's many common needs, and we know there's efficiency in services. However, there's many challenges in bridging aging and disability. There's been historical segmentation of service systems. So we have aging and we have disability, and in most states they're separate. Of course, things have changed to some extent, which I'll talk about. Now we have the Administration on Community Living. We have different philosophies, terms, and definitions. Person-centered planning is now being embraced by aging like it's something new. I have to tell you that just before the Administration on Community Living was assembled, I was asked to do a report on bridging aging and disabilities, and was very interesting to me because I was asked in Washington to come speak about it, and I had the head of aging and people from CMS and the head of National Association of DD and of aging, and I was like, why are people so interested? And so one of my recommendations was that they look at person-centered planning. Well, and that they talk about more bridging, and lo and behold, 2 days later, they announced the Administration on Community Living. Wow, I've never had such success. Of course, I had nothing to do with it. But all the things that I recommended are actually things that are happening, and they were already being planned. And so now person-centered planning is kind of being shoved down the throat in aging, and they're trying to understand it because they had what was called options counseling, which is a little different, which is, picking which of these options you want is not the same as thinking about what you really need or want. So it's just interesting to see different terms, and they're very distinct fields of knowledge and practice. If you look at the gerontology journals, there's very little about intellectual and developmental disabilities. And we're starting to see more and more in the developmental disabilities around aging, but still not that much. There's protection and duplication of funds. There's always that issue, but there's missed opportunities for knowledge, translation, innovative policy change, and co-funding. So how do we bridge the two? Well, certainly exchange of research is important. And I've done a couple of scoping reviews around family caregiving and around health promotion, and trying to see how we can bridge those. We can certainly adapt interventions that we've each done. You're starting to see the aging community getting Michael Small's training on person-centered planning, and that's just one example. Development of policy embracing ideas from both fields. So let me give you some examples of some adaptations that come from aging. Geriatric assessments. There's been some work on that, and they're very much based on the general geriatric assessments. So Joan Hahn and colleagues went and did these assessments with nurses and going into homes, and found lots of issues that wouldn't have shown up. I know in the Netherlands, I remember when they did this massive looking for sensory issues, and found that many people with IDD had hearing losses much earlier than you would expect and needed hearing aids, etc. Or people had visual visual impairments much earlier than many of the rest of us. So these assessments are really important. There's a falls prevention program that called the Otago program that was tested on people, adapted and tested on people with IDD. That's another example. Chronic disease self-management. So Kate Lorig has developed these wonderful diabetes self-management with extensive research, and it's considered evidence-based and really has the stamp of the federal government all over it. And it was adapted in Albany by Phil McCallion and his group. And so they did these diabetes adaptations for DD, developmental disabilities. And I haven't seen it in the literature yet, but I've heard presentations about that. In fact, now when you see the request for proposals for falls prevention, for these chronic disease self-management, they often include IDD in the actual request. In fact, we just got endorsement from the Administration of Community Living for the Health Matters curriculum as an evidence-based curriculum. In terms of family caregiving, our Family Support Research and Training Center very much included aging in it in a big way. And the new one that's being funded at Pittsburgh actually was heavily in the aging arena. There was a project called Caring for the Caregiver at the Kennedy Center in Southeast Connecticut. This was a while ago, and it was through the Agency on Aging. And I love this project because it gave funds for people with IDD to take care of their parents. And it was through their aging center there. And then there's been these aging in place, aging in community, disability and aging friendly communities, initiatives around environmental issues. And I always thought we have aging friendly communities, whole initiatives around it. How is that different than disability friendly communities? It's the same idea of breaking down barriers, physical type barriers in communities and other kinds of barriers. Another issue is around employment and retirement. And we know that 16% are in integrated employment according to the National Core Indicators, and in full-time employment, 13%, according to the American Community Survey. And mostly, like 43% are in facility-based and non-work settings, including retirement options such as volunteering, recreational and health promotion activities, senior center participation, and continuing education. So, we're trying to move away from workshops, but there's other kinds of programs like this that many have moved into. And some states are no longer doing funding facility-based, but some are going to these other kinds of day programs. So here's a transition to retirement program. And this was developed by Roger Stancliffe and Christine Bigby and others in Australia. And it's a cool program. And it's looking at attending community group or volunteering, trying to figure out what an older person with IDD would like to do as they retire. And it's kind of like a gradual retirement. Many of these people were actually like in day programs, and then 1 or 2 days a week, they would start to transition to retirement. They used mentors from the general community. They had planning meetings, they trained the mentors, and then they have a choice of activities and mentors, and they provide ongoing support. But it's a cool program, and they have they have publications about that. What was kind of cool, you see some people wanted to do choir, some wanted to do gardening, so all kinds of activities that they picked. We had done a curriculum called Person-Centered Planning Later Life quite a while ago. If I tell you we did it in 1990, okay, in case you think person-centered planning is new, it came out in 1996, but we'd worked on it a long time. And more recently, Lieke Van Humen has been doing a newer version under her leadership, a newer version of it called Engaging with Aging, Person-Centered Planning for Later Life. And this one really has some of the newer concepts that we're talking about, very much about looking at the voice of people with disabilities and how they feel about their life, and understanding aging and life stages, thinking about their life stories. She actually did her dissertation looking at life stories of people with IDD, and it was actually fascinating to see about how they look at their life in different aspects and what was meaningful in their life. It's around rights and choice making and thinking about that. There's quite a bit about healthy exercise and healthy eating, stress reduction, where we live, friendships and community supports, work, volunteering, and free time, and review and goal setting. Very hands-on, all kinds of wonderful sorts of activities. They had people were making posters and were presenting at conferences. Very much engaged, these people. This was a center-based kind of program because they did it at the agencies where people were. So anyway, this is I would say a much improved version and really taking in some new concepts in terms of how we think about person-centered issues in later life. So now we have opportunities for common ground. The Administration for Community Living now really is both aging and disability. The Aging and Disability Resource Centers are supposed to work both with disability and aging. We have done research on them and found that they weren't doing very much with IDD, and what they were doing we didn't think was very meaningful. It's supposed to be like a one, center of contact, and then you get sent to different places. I say one point of contact. Recently, with the virus packages, emergency virus packages, there's been money for the Aging and Disability Resource Centers, and many of them are working with USense now, or they're actually working with the assistive technology programs, which are in some of the university centers on disability. The National Respite Act is disability and aging. The National Family Caregiver Support Program does include some money for families who are caring, older families who are caring for an adult with developmental disabilities. This is something we've worked on for years, trying to get them to do that. I'm going to tell you more about the National Alzheimer's Project Act in my future slides. One thing nice is that Matt Janicki from our network has been appointed to their advisory group. I would also mention, because this is actually newer that I didn't put on the slide, is the RAISE Act, R-A-S-E, which is an act that is looking to develop initiatives around family caregiving for in general, which includes aging and disabilities. Actually, as part of their national advisory group, they have Joe Caldwell, who's from our network, and also some ARC leaders are on there. So they do have some developmental disability represented on that. And then I mentioned about chronic disease self-management, and that now they include people with IDD as part of the request for proposals. I want to say a little bit about the Alzheimer's disease. The National Task Group on ID and Dementia Practices has been extremely active. We kind of started it as part of our center and partnered with AADMD, the American Academy on Developmental Medicine and Dentistry, who really house it now. And one of the projects that came out of the Administration of Community Living around this topic actually mentioned IDD in the request for proposal in 4 states. Florida, Maine, Rhode Island, and Hawaii were actually using a lot of the National Task Group and Dementia Practices material as part of that. This National Task Group has done 3-day workshops on dementia in 17 states with 1,300 support workers with 500 staff using the curriculum. They co-sponsor the National Down Syndrome Summit for family caregivers. They have an online support group for families. They have newsletter. They developed a guide in Rhode Island. And they've got a ton of material. They have a wonderful website. So if you're interested in that, I did not talk a lot about dementia, but that is certainly a big issue with this group. So we need to build from the best of the disability and aging systems. So involve some planful cooperation so we can help institute proactive and helpful screenings, interventions, and programmatic supports and collaborative cross-cutting research. I had the honor of participating in a National Institute on Health summit on dementia. And they brought in all kinds of experts in the field, and I was able to get my 5 minutes in there. I was very honored to get 5 minutes in this 2-day NIH symposium. I think I was the only one that actually represented disability. This was in, I think, 2016 or 2017. They were, I don't know if they've done the second one yet. They're doing a second one. And I think Matt Janicki's, making sure to try to get in there. And again, that one was so interesting to me because they spent half a day on a new idea, self-determination, and actually having a person with Alzheimer's actually speaking. So that's not new for us to think about people with disability speaking up at a conference or doing research that looks at the views of people with disability. So they are embracing some of that now. We need models to cooperatively deliver services and increase the public benefit. Aging does a better job than we do of getting people right into the system. They don't have those big waiting lists like we have. And given the growth of the aging population, special populations call for special attention and collaborative planning. We don't want to just be melted into that population and not addressed. So what about looking, this is my last slide, looking to the future. Certainly the greater use of technology and universal design to address age-related changes. Well, we can't say enough about that now. I think that some of us have been very skeptical because of the digital divide and the fact that many of the poorer families, et cetera, don't have technology or don't have good technology. Now we've been forced to think about it as we see school systems giving out iPads and us trying to help people with hotspots and trying to do all kinds of training around technology. And I'm seeing more and more of that. And I think we're going to see more and more use of technology as people are going to get used to it. And also universal design. So if we have more accessible places, it's going to be more accessible for everybody. We need transportation assistance. That's still a huge one. It's around transportation, and especially as when people get older, if maybe some people who used to drive can't drive anymore. There's going to be pressure on system and the families with the lack of the workforce and community capacity. We see that now really exacerbated because of what's going on with people afraid to go to work and people not being paid enough. There's a growing recognition of supportive decision-making and interdependence. And there's nothing wrong with interdependence. And it can be in many directions. We all help each other in different ways. And we need to research on better ways to bridge aging and IDD. So I have my contact information here, and I will turn it over to Deborah.
Tamar, thank you so much. And we know that much of the policy that was developed is a result of your work. A few comments and questions from our audience. We wanted to respond to a comment and let people know that New Jersey does have a policy on allowing people with developmental disabilities to have a support person in the hospital that can be found on the Department of Health's website, as well as the policies on care. and that on the Department of Human Services work group is a dashboard on the numbers of individuals with developmental disabilities who've been affected by the COVID-19 pandemic. And we thank our Division of Developmental Disabilities for their vigilance in testing and their directness in reporting. A question about where you get the Get Future Now material, and you've given your website. Another specific question that we have is, what age would you recommend a geriatric assessment?
Oh, well, that's a good question, because aging can happen. You know, there's many ways of thinking about aging. You know, there's chronological aging, but we all age in different ways and different. So I think it really depends. For example, a person with Down syndrome, I would start earlier than for other people. And I think you might want to start, say, in the 50s for a person with Down syndrome, because you're going to find a lot of things that are going to be earlier. Sensory losses will be earlier too. Maybe even before that, because you're going to see visual, hearing, those things are going to happen earlier. So I think for most people, it may be age 60. I think it really depends on the person. If they have more severe disabilities, it would probably be earlier.
Thank you. We wanted to call attention to the fact that New Jersey is one of the national community of practice for supporting families states, collaboration with the Division of Developmental Disabilities, the Boggs Center, and the New Jersey DD Council. As you pointed out, the numbers of people with developmental disabilities living with aging families, even being their families' caregivers. Do you know of any programs that have have been targeted to thinking about the person with disability and the aged parent as a unit and providing integrated services such as for that unit?
The only one I know about is the one that I told about that had been at the Kennedy Center in Connecticut. But that ended when the funding ended. So I actually don't know of any programs that are actually, I think it may be happening, but I think that we need a training program for people with DDs so that they could do that. One of the trainings that we did a couple years ago, there was a guy that we interviewed who had IDD, and he was so proud of the fact that he was going to a close friend of his parents to take care of an older lady that needed help. And that was his volunteer job, and he was very, very proud of that job that he was doing. He had 2 other jobs. So I think informally it may be done, and he may be getting some support for that. We actually wanted to do a program like that to train people with IDD to be caregivers, not necessarily to their parents, but it could be to their parents. And we thought that Voc Rehab would pay for it, and then they came back and said we can't pay for it. So I don't know. It didn't go anywhere, but I think it's a good idea, because I think a lot of people with IDD, you know, that physically could take care of their parents. I think that would be really a cool program to do.
What a great suggestion. You mentioned that the earmarking in the COVID-19, the federal CARES legislation, that there were monies targeted for the ADRCs, the Aging Disability Resource Centers. Do you have any suggestions for strategies to making sure that people with developmental disabilities are also included in the work of ADRCs, particularly now?
It's really important to reach out to them. I know that they're reaching out to the they have to reach out to the technical assistant, to the assistive technology centers. And I think the assistive technology centers deal a lot with developmental disabilities. So, you know, that's one aspect. We reached out to ours, and not much happened. They said, oh yeah, we're very interested, but I haven't heard any more. But I know that I was on some of the calls around this, and there's some states, one of the states is the USAID is actually running the project with the ADRCs. And I don't remember which state that was, but they were actually running the program and working with the ADRCs. Mostly the money's going straight to the ADRCs. So you really just have to reach out and have a relationship with them. In our state, the ADRC was very interested, the one that's in our area, because we have good relations with them. The state unit on aging, though, wrote the proposal, and we don't know if we were included. So I think it's just important to contact them early on, which is what we tried to do. But hopefully you have some good relations with the ones in your state, and you try to get in there. We have done training with the ADRC in our local area that they did invite us to do training on aging and IDD.
Thank you. I turn back to some of your information on end-of-life issues, death and dying curriculum, which are issues that are accentuated now, but are enduring issues beyond COVID, and a question about hospital ethics committees. Are they required to have a person with intellectual disabilities or a family member to inform their functioning as a committee and their decisions?
You know what? I don't know the answer to that, so I can't really answer that one. I don't know if they're required or not. Maybe you know. Do you know?
No, I don't. But are you aware of ways that that you heard of both in Illinois or other states where the disability perspective, the view, what we know about the values and contribution of people with disabilities have been infused into ethical decision making, or is that a continued struggle?
I think it's a continued struggle. The places I know that have done a really good job is, for example, Rush Hospital, which is in Chicago, and they have a whole disability committee, and they actually honor someone every year who's done a lot with disability, and they're very cognizant to have disability as part of their initiatives and part of some of these committees. So, you know, I think that might be a good place to look at for some guidelines around that.
Thank you. And one more question about health and advocacy before I turn back to you for some closing remarks. Are you aware of programs where or strategies for people with disabilities who don't have guardians or family members, programs or strategies to enlist healthcare advocates or coaches to support people in supported decision-making about healthcare prior to hospitalization or a serious diagnosis?
Wow. I'm not sure about that in terms of, I know that, you know, for people who don't have, you know, there are some, in terms of like future planning, pool trusts, that kind of thing. In terms of around medical advocacy, I don't really know the answer to that one.
Thank you. And one more question. You had mentioned 5 states permit assisted suicide end of life. I know there's concern that's been expressed by our participants. Can you name those 5 states, or can you direct people to a resource by which they could look that up?
The 5 states. I thought that potentially Oregon might be one of them. I think that was like one of the first ones. So I could probably get the name of 5 states and get that to you later. But I
Good,
know that Oregon was one of the first. One of the issues with that is, you know, Netherlands has been a leader in this assisted suicide, and there's been some critique of that. Then on one side, people will say, well, in the Netherlands, you know, they have all these protections and they have a committee, and they also provide better supports for people than we do in this country. So that's part of the reason. But then other people think that that's really even abusive in the Netherlands because they're kind of lax about it.
Well, thank you for responding both to that complex issue and for the wonderful array of issues, materials that you provided. Tamar, would you like to make a few closing remarks before I end the session with some details? And again, thanks to you.
Well, thank you for this opportunity to speak on this topic of aging and intellectual and developmental disabilities. And I welcome more questions if you have, and I can try to answer to Deborah, and so people can, if they have more questions later. And I really wish everybody to stay healthy, and thank you for participating in this.
Well, Tamar, our thanks to you. And I particularly want to note that even though you spoke the day before the Administration on Community Living was announced, bringing together aging and disability, I know that much of the decision-making and our collective ability to support people is based on the work that you and your colleagues have done. And so we are deeply appreciative of you being with us today, your willingness to jump in and jump across distance by being with us virtually. I now turn to all of you attendees and ask you to complete the evaluation. It will pop up after I finish speaking. You need to complete the evaluation for certificates of attendance and continuation. Thank you all for joining us at the Developmental Disabilities Lecture Series this spring virtually. And again, we would particularly appreciate your comments of how this format worked for you, how it might be improved, and what you recommend. We mourn with all people, and particularly members of our disability community, who have been affected by the COVID virus, both in terms of illness and loss, and also the loss of contact and services and supports. We wish you, all of you, your families, well, and hope that you will join us at future sessions. Please avail yourself of the resources on the Boggs Center website about COVID-19 and virtual programs to provide support and information. Stay well. Thank you for being with us today. Thank you for completing your evaluation. I will bid farewell, but please stay as the evaluation form will pop up on your screen. Thank you all again, and our best wishes for good health.